What is this casino? What is it about?
Mic check, mic check, mic check.
Voted to be.
Good.
Mic check, mic
I
check,
did. How was yours? Big. Did you cook?
mic check, mic check.
Nice.
Just check. We're live on Facebook with just the screen.
Okay,
And so we just check audio and stage heard it. So,
perfect. All right. So we'll just remind people
Sounds good. Sounds good.
Good morning, everybody. Welcome to Central Health. I'm Ted Burton, Chief Communications Officer here at Central Health. Today we are hosting the first of two community conversations with our finalists for President and CEO of Central Health. Before we get started, would you please warmly welcome Dr. Patrick Lee. So I want to talk a little bit about the meeting itself. First of all, we do have interpretation, Spanish language interpretation. If you need that, we can provide you with a headset. This meeting is also being broadcast live on Facebook and via Zoom. We also have Spanish language interpretation via Zoom. First, we provided both candidates with a series of questions, and we will walk through those questions. Additionally, we will take time for the audience to ask questions, and we will take questions via Facebook and via Zoom. We likely won't have time to answer all the questions in the next hour, but we will receive the questions and answer them and post those on Facebook and our website. So with that, we will get started. This has been a long process to get you here today. And on the screen, you can see the robust engagement and communications process that we went through to find the finalists for our new CEO. And so we're really happy to have you with us here this morning. And you battled the traffic on Thanksgiving weekend, so we're glad you're here. Why don't we start let me just provide the lay of the land about Central Health. We're the Travis County Hospital District. We provide access to care for 1 in 9 Travis County residents. That's about 150,000 people every year. We have a budget of $750 million. This year, about $80 million of our budget will go towards the direct practice of medicine. We are part of an enterprise, so Central Health, Community Care Health Centers, and Sendero Health Plans, our nonprofit health insurance company, health maintenance organization. So let's begin. Would you please introduce yourself to the people that are here in the room and the folks that are watching via Facebook and Zoom? And it's on.
Thank you, Ted. Good morning or good afternoon. Morning, 11 o'clock. Good morning, everyone. It's truly an honor to be here. My name is Pat Lee. Please call me Pat. I want to begin by actually sharing with you a bit of my background, maybe some things you wouldn't see on the CV, give you a sense of who I am, where I come from, and then talk a bit about why this opportunity is so compelling and so exciting to me at this time. I grew up in California, in the Bay Area, San Francisco, and my mother raised me to believe that I would be worthy of unconditional love. And I begin there because as I experienced the typical disappointments of childhood, I realized that I was never falling below this level of worthiness of love, and so I learned to be unafraid. As a medical student, I had the privilege of hearing somebody give a talk that changed the course of my life. This was Dr. Jim Kim. He's one of the co-founders of Partisan Health, and he was giving a talk to about 100 of us in the audience. And at one point, as he reflected on the early days in central Haiti of Partisan Health, he looked up, and I felt like he looked me in the eyes, even though I know that he didn't, but it felt that way. And Jim said, optimism is a moral choice. So when they began the work in Haiti, there was no reason to believe that they would be successful in actually demonstrating to the world that you could take care of people with HIV, people with drug-resistant tuberculosis in the most remote and least resource settings of the world. No reason to believe that they would inspire a generation, myself included, sitting in the audience. It was the right thing to do, and then you'd have to make the road by walking it. And so optimism is a moral choice. But then Jim said, good intention is not enough. You have to learn how to deliver. If you start down that path and you don't succeed, then you've used up precious resources. Financial resources, political resources, will for change. And you may have made it more difficult for those who come after. So if you start down that path, you need to learn to be effective. You need to learn to actually deliver. I remember a light bulb going off in my mind at that point. I thought that is what I want to learn how to do. Now, as I was a resident at Mass General Hospital in internal medicine and primary care, I didn't see a formal training pathway that would teach me how to do this. So I went to Rwanda after I finished my training. I worked with the late Dr. Paul Farmer, and I want to share with you some of the lessons I learned from Paul because I think they're relevant to our work at Central Health going forward. They've been relevant throughout my career. So lesson number one was the way that Paul led. It was absolutely clear why we were all there. The sense of mission was deeply felt. It was personal for us. And it was just as clear how we were meant to treat each other, with kindness, with respect, and also with a level of vulnerability that we would give and receive help. We would have each other's backs. It felt like family. And I experienced in that setting what it was like to be clearly connected to mission and to be surrounded by people who felt like family. I thrived in that environment, and I think we overperformed our expectations as a team, what you might expect on paper. And since then, I've experienced, as many of you have likely experienced, settings where the mission is not as deeply felt. Maybe the words are on the wall, but it's not as authentic. Or we don't feel safe, and maybe we're looking for other options. And that team will consistently underperform. And I learned that that difference between those two teams, sometimes the same people in a different context, that difference is perhaps the greatest force for social change in our world, more important than money. And what makes that environment happen is leadership. Not just the leader, but leadership broadly defined. How do we together create the environment of one trunk, many branches, where the one trunk, our sense of mission, our core values, why we're here is deeply rooted. It must be. It is deeply rooted in Central Health. And the many branches are all of our diversity, our full, rich diversity, who we are, where we come from, how we see this, our voice. We don't want to collapse that into a uniform, homogeneous structure. We actually want that to flourish, and we need those branches to be connected to the whole, to each other, to the center, which is the work of leadership, it's the work of leading with love. It's what I experienced from Paul in my first job, and I've aspired to do ever since. So that was lesson number one. Lesson number two from Paul was about how we innovate for health. Innovate in a setting that didn't have a lot of resources. This is Rwanda about 10 years after the genocide, not a lot of money. And also the need to take health broadly defined. Not just clinical care, but what we might call public health, social care. So I'm going to share a couple examples with you. When I had a new patient with drug-resistant tuberculosis who's diagnosed and we had to treat that patient, that's a difficult course of care, about 18 months of treatment. We would actually do a wealth assessment of that patient. And if they fell below a certain threshold, which they usually did, then as a doctor, I could write a prescription for a house. And a team would go out and build that patient and their family a concrete floor, a tin roof, 4 well-ventilated rooms, so that they weren't giving that disease to their family, so they could actually complete that difficult course of care. And we were able to demonstrate that that was the most cost-effective way to actually get all the way to cure for this difficult disease. When I had a new patient with HIV, not only would they come in and get their medicines every month, but they would get food for a family of 5. Why 5? Because if you give someone food for 1, they'll share it and be malnourished, so food for 5. And on top of that, they would spend a couple hours in the teaching garden, where we were blessed to have a couple agricultural engineers from Dartmouth who would show patients the benefits of no-till soil management, keep the vitality of the soil, or different drought-resistant, more nutritious crops that they might be able to experiment with that we knew would work in that environment. And after 10 months, when that patient had graduated from the food support, there would be a agriculture community health worker who would spend a half day a week of free labor to support those lessons for the first growing season. And it was when, after that first season, that patient, that farmer's corn was a foot taller than it was in the previous season, or that any of the neighbors, where that's when the magic started to happen. Because that difference in a foot of corn was often the difference between not enough and a little bit of extra. A little bit that could be invested in maybe a goat, or sending the person's children to school, paying for the school fees, the books, the uniforms. And not only for that person, but their neighbors would look over the fence and say, Cynthia, talk to me. What is going on here? I need my corn to grow a foot taller. How do we do this? And we changed the nature of the conversation. All of a sudden, we were talking about trust in a very dynamic way. And we would notice that women might come and deliver their babies in the health center because of these kinds of experiences. They might get their kids vaccinated. Trust is a really nuanced concept, but it is the essence of what we do, which brings me to the third key point. I learned from Paul and the work in Rwanda how we earn the trust of a community that experienced immense trauma. The genocide in Rwanda, as you may be aware, was hand-to-hand. It was with machetes. And it was unfortunately true that in this country of 10 million people, every single person had either experienced violence, witnessed violence, or perpetrated violence. It was a complete penetration, unfortunately. And the first hospital that we had to rehabilitate was a burnt-out concrete structure that had graffiti and blood on the walls that said, those of you who we don't get to, AIDS will finish off, because there was a systematic rape campaign. And I learned and observed and participated as a newly minted doctor as we beautified this campus, as we landscaped those walkways, as we put up a children's playground. And Paul Farmer personally installed a koi fish pond on the grounds of every hospital and health center they worked in. I want you to imagine there's no running water here. We are off the electrical grid using generators at night for electricity. And this is an open campus. So patients are walking through, inviting their friends, their community members, come take a look at this. This is totally different. And weeks later, when the systems began to arrive, essential medicines, electronic health record, the satellite link-up vehicles, training, and so on, we were having a totally different conversation, grounded in trust. Now, as I've had the privilege of working in different settings over the past 16 years, I have not seen that every healthcare CEO, every healthcare leader understands that our core business is not insurance, as important as insurance is. Our core business is not drug delivery, as important as medicines are. There's some things that I can refrigerate and put into your arm to prevent disease that are important, but that's not our core business when we're talking about equity. Our core business is trust. Our patients need to believe, truly believe, that we have their best interests at heart and agree to let us inside. Have a conversation with us around what does whole person health look like for you. That might be housing, it might be food, it might be medicines, counseling, surgery, transplant, whatever it is. We need to then bring that whole person care to you in a time, manner, place that is acceptable to you. That's easier said than done. But if we do that, that person will be healthier, they will be happier, the cost of their care will also be lower. They won't need the hospital as much. Who wants to be in the hospital if you don't have to be? And we can use the savings that are generated from not hospitalizing people necessarily to create more access, high quality access to everybody who needs it. So why Central Health? As I've gotten to know this organization and learned about the history and met some of the amazing people, the board of managers, the senior leadership team, some of our key partners, it's clear the mission is alive and well, deeply grounded. There's a lot of strength in the organization. So I look at the financial management, I look at the equity plan, I look at the degree of comprehensiveness of the conversations that have been had, the rich network of partners. This is an organization that has been working diligently and has a lot of strengths to build on. I'm also aware that the funding that has been empowered to Travis County from the taxpayers, from the people of Travis County, is actually remarkably strong and robust. Having grown up in California, worked in Massachusetts and New York, I'm embarrassed to say it was a bit of a surprise for me to become more aware of the structure and realize that Central Health has been empowered with the resources it needs to actually reach people. The first and most pressing question every morning for the central leadership team might not be, is there enough money to pay for this? Money is always important, don't get me wrong. We have to be wise stewards, but we can look beyond. Are there resources for this to ask what needs to be done to close the gap in care, to close the gap in when people die, whether they're east or west of I-35 or which zip code that they might live in. We can talk about health outcomes and equity, and know that the people of Travis County stand behind us in terms of resources. That is an amazing opportunity. I believe that together if we focus on trust as the core part of our business, if we recognize that people are the heart of everything that we do, and we intentionally work for that, if we engage in this continuous conversation, together we can reduce the disparities in Travis County. I would aspire on my watch to cut those disparities in half, working in partnership with all of you. It's really a privilege to be here today, and thank you for the opportunity.
Thank you so much. I'd like to make a couple of introductions, and also we do have 3 seats, so I invite you, if you're standing, to please. The front row is always the scariest, but also the most fun. But I'd like to introduce our Travis County Judge, the Honorable Andy Brown, is here with us in the audience. And 2 of our Board of Managers, Cynthia Valadez and Ann Kitchen. And we do have questions coming in that we will get to, and I know there are people in the room that may have a question as we move forward. But can you tell us more about your healthcare, hospital district, and clinical experience?
I've been a practicing internal medicine primary care physician for the past 20 years. I speak Spanish. I work without a translator, whether I'm navigating core topics like hypertension control, or we're talking about new diagnosis of cancer or end-of-life care. It's the heart of what I do, and it's where I learn the most about what's needed. I'm also a physician executive who's had broad experience, domestic, internationally. Let me walk you through briefly some of that history. So after Rwanda, which you heard about, I was in Liberia as the medical director of Last Mile Health, a nonprofit organization there. And amongst the things that we did, we partnered with the Ministry of Health around scaling up HIV services across the country, directly observed community health worker-led care for HIV very successfully. After Liberia, I was back in Boston working with the Mass General Hospital, where I had the privilege of building a new training program in global primary care. This was an attempt to try to teach to new doctors what I had the privilege of learning in Rwanda and Liberia, empower them to be able to go further faster in making health happen. I was in Uganda when my son began to walk, my son Miles, and that was a signal to me that it was time to come home. So I worked in Cambridge Health Alliance. This is a large public health system in Massachusetts, where I was responsible for leading an internal medicine teaching practice and transforming into team-based medical home care. And we also improved the quality to the best in that system while we were there. I was recruited then to Lynn Community Health Center. This is a large federal qualified health center in Lynn, Massachusetts, where we serve a predominantly Latino population. And I was first asked to lead the EPIC implementation, the electronic record. That can be a complicated thing, and we did that as a team very successfully. We had a large unionized workforce, and we built the plan together with that team so that there were no grievances or complaints as a result, because we did it together. And the results were very effective. We had a much increased productivity, efficiency, and improved quality of care. I also had a chance at Lynn to lead the population health efforts around, in particular, hypertension improvement, where we became the best in Massachusetts on our overall scores. We won a couple national quality awards as a result. And then I was recruited to the Mass General Brigham Salem Hospital. It's a large community teaching hospital. I actually served the community of Lynn. I served as the chairman of medicine there. And this was during COVID. So that was a difficult time, as we may all remember. There were about 400 doctors, trainees, staff in the Department of Medicine. I led our department response. And I'm really proud to share that although we were the busiest community hospital in Massachusetts throughout the pandemic, because we were serving the community of Lynn, we kept the mortality rate in the hospital down under 9% at a time when the national average is about 20%. So it's still too many people dying, but it was less than half what the rate was nationally. There were hundreds of people who survived as a result of the team's efforts there. I also was part of the executive team, and when I began the work there, we were losing money every year. And so I was part of the team that wrestled with all the ways in which we were going to improve the bottom line. And we together oversaw a $70 million financial turnaround. My specific responsibility operationally was to help safely transition the critical care services from a secondary hospital to our primary hospital. And we did that in a way that was safe for patients, but also safe for staff. They didn't feel abandoned. And we were able to save about $17 million a year. With that, we won a system quality award there. In my most recent role, I was recruited to Brooklyn to be the first chairman of medicine for a new health system, 3 hospitals, 27 ambulatory sites serving a population of about 1 million people in central Brooklyn, East New York, mostly Black and Latino, who together had about 11-year life expectancy gap between the heart of our community in Brownsville and someone with the same age, race, and gender just a few miles away in Manhattan. I understand actually that the latest data from 2022 reflects that the life expectancy gap east and west of I-35 is about 10 years overall. So this is a space that I've been in before. And in that setting, I integrated our 3 hospital staffs, about 570 doctors, trainees, and staff. Also helped us reduce the mortality rate in the hospital by about 1%. That actually translates into about 300 people who are no longer dying, who would have died if that hadn't changed. And then the contribution I'm most proud of in that role was actually helping us understand and focus on the 11-year life expectancy gap to create an equity plan over 3 years that would help us advance the access and navigation for patients, the primary care and behavioral health, and the team-based care, and the recruitment of the new providers, and then cancer, heart disease, and diabetes, the 3 leading causes of early death in that community, and really make that the focus of our work. And that brings us to the present moment. So thank you for the opportunity.
Thank you. So here in Travis County, more than 60% of Central Health's patient population identifies as Latino. More than 50% speak a language other than English at home, and 40% have one or more chronic condition. You've obviously worked with some very diverse populations as well. What are some key lessons learned as to how to serve and care for this population, sometimes called the safety net population, and how would that translate here into Travis County?
This is what I've been doing all my life. I'm extremely passionate about this particular challenge. And while there's so much that I think we could say here, I want to focus on 2 key points. One is trust. So we've said how much that's important, but how do we actually earn that trust? And again, there's many things here that we could discuss, but I think it begins with broad and deep listening, continuous listening. Are we actually with the people we're serving? Are we understanding how that care is received? Are we listening to all of our internal and external stakeholders? Are we listening to all aspects of our public, those who access our services and stay with us, those who have come but perhaps not maintain their enrollment? What makes that hard? What would it take to get you back? And very importantly, those who perhaps have not accessed our services, and there might be multiple subpopulations there. What would a trusting portal of entry look like for you? How do we reduce the barrier, make it easy for you to get what you need? Let's make sure that you're not invisible to us. So listening deeply. And in that listening process, I think we would understand some of the assets, the strengths, many strengths, I would imagine, and maybe opportunities, areas of weakness, areas where we could share the data more effectively, we could collaborate more effectively, we could build together and maybe not duplicate our efforts, where we could innovate and get bold. From that place, then, we could then do the next step, which is whole person care. This is really critical. Health is not just a disease or treatments, it's everything. In fact, we know that the conditions in which we live and work and play and age and die, the social determinants of health, those are far more important to your overall wellness and lifespan than what we might do inside the clinical encounter. And if we're talking about health, we talk about big H health, broadly defined. Understanding the problem is the first step, but intervening on those issues requires humility and partnership. Central Health may or may not be the most expert stakeholder in meeting the needs of a patient who has a housing gap, let's say, or has a employment gap, or needs transportation services. How do we partner effectively with the same goals, with transparency and trust, to show up and meet the needs of whole person care? I think easier said than done, but these are the kinds of things that I think are before us, the opportunities before us, and I would love to see that happen.
So as CEO, how do you personally ensure that every person, no matter where they were born, what language they speak, their gender identity, their sexual orientation, their income level. How do you ensure that everyone will, how would you ensure everyone will receive the best possible care?
The first thing is to state clearly that I believe health is a human right. I imagine we share that belief. From there, I believe our core business is trust and all the complexity that I've mentioned. And because trust is the essence of what we need to do, the key to success is our people. It's very difficult to give what you don't have. Trust is created in a series of one-on-one interactions or group interactions that are happening all across our system every day, whether on the phone, in person, in the community under the bridge. Our people in Central Health, our partners, need to feel the love so they can naturally give that love to the person in front of them. Again, easier said than done. So that requires leadership that understands that that is the focus. If we're building for trust, we're building for people. That may take time. It takes intentionality. It takes clarity around what does success look like. It takes hiring and coaching and supporting and cascading that sense of care, leading with love from the CEO to the executive team, to the management team, to the front line, and getting feedback. How are we doing? How can we do better? The one truck, many branches. So that's critically important. I'll add to that part that Jim Kim said, right? You have to learn how to deliver. That's really important. And so what I've learned over the years, actually, is to ask the most important question, which is what are we really trying to accomplish? When we understand what we really need to accomplish, we put that in terms that we can measure and or assess. Not everything that matters can be measured. And then we ask the same question, where are we now compared to where we need to be? What's the gap? Why is the gap there? How do we engineer the system so that quality is routine, so that we're actually getting the results we want every time, every day, that the easy way is the right way? Again, easier said than done, but has been done, and I've had the privilege of doing that in multiple different settings. And then keeping our team laser focused on what needs to be accomplished to get from here to there, if that's our goal. Trust, people, equity, services, and so on. Keeping us focused on doing the things that must be done and also not doing the things that perhaps are not in the critical path to get to what's most important here. If everything is a priority, then in the end, nothing is a priority. So while there are thousands of things that need to be done, if we try to do thousands of things at once, we won't be successful. So helping us focus, I believe, is also a key part of that.
I'm going to combine a question that we provided to you with one that we received on Facebook Live, but could you, and you've done this already, but could you sum up your definition of healthcare equity? And then from a person on Facebook, how would you address health inequities specifically for the Latino community here in Travis County that are decades, if not longer, old? So a combination of your personal definition and how you address the inequities here in Travis County, specifically for the Latino community.
Equity is a really important concept, and there's a way of thinking about equity that looks like opportunity. So does everyone get to the starting line in a way that's fair, where they have the chance to run their race fairly? And opportunity is very important. Access is very important. Don't get me wrong. But when we talk about healthcare equity, I think we have to go further than opportunity. I think we talk about outcomes. Did we detect that cancer at a stage where it could be cured? Did we cure it? How many people went blind this year from diabetic retinopathy? Do we know everybody who's at risk for this? Have we built the systems to access them, to screen, to intervene, to prevent blindness, to prevent amputations? We need to talk not just in terms of whether you can get the care, but what are the results of that care. I believe that is the key to health equity for me, and will be a critical part of my leadership, is to, as a practicing clinician, push us through opportunity access and be very clear on the outcomes that matter. And so if I think about the Latino population, we can extend this question. What are the outcomes that are most important for our Latino patients from a health perspective, from a justice perspective? Agree on those things. It might be something related to diabetes, high blood pressure, maybe depression. And then how is that care received? How would you like to have that care received? Very likely we want that care in a language concordant fashion, right? We want to hear from a provider in our own mother tongue, Ideally, somebody who we believe understands our journey or has even walked our journey. So we get proximal, we get real close, we collapse the social distance. We make it really easy to receive that message from somebody that you're more likely to instinctively trust because we share so much in common. And then ask the question, where is that care being provided? In what manner is it providing? Does the digital platform work for you? If not, how could it work for you better? When are your hours that you can actually access this care? Are we providing it in a time and place that works for you? Maybe we need to go a little later in the evening. Maybe the weekend's really important. Maybe if we partner with your church and provide some services there, or make sure that we're in the schools effectively and we're getting way upstream, what does that look like for you? What would success look like? And then as we're designing that care, let's do it together. Let's make sure that we feel the problem and your voice is in the room, helping us understand, why isn't this working? Of the options that we could put on the table, let's test them together and let's get your thoughts about whether that's working. Let's test in different environments. And then as we're moving forward, as we're seeing the fruits of our labor, let's continue to check in and let your voice drive this care, shape this care. Let's co-create this vision of health together. And I would extend beyond that, there are additional populations that are not receiving what they need beyond the Latino population. Let's figure out which populations we prioritize. Again, we'll have to focus at some degree. If everything's a priority, nothing's a priority. But I think we can do more than focus on one population of need. We have to ask that question more broadly and tailor that conversation and listen and engage and co-create that vision of equity together.
So regarding healthcare equity, Central Health recently adopted a 7-year healthcare equity plan, which is a change for us. It changes the model of care where we will be providing more direct practice of medicine through our own clinicians and clinics. We will still work with a network of providers, but it is a significant change in the history of this community and this organization. And I'm just curious, and we've heard a little bit about this already, but what are your thoughts on this new-ish approach for Central Health? And you had a chance to review the plan. Do you have any observations or initial thoughts on where we're headed? Things that you obviously would do, but perhaps you might add to or change?
So it's a really good plan. I was delighted to get to see the plan, understand its provenance. How was a response to a deep listening in the Community Health Needs Assessment? How was the plan created and conversation adjusted, adapted? No plan is perfect, no process is perfect, but this process seems comprehensive, robust, valid, and the plan itself has excellent bones. I would love to see that plan come to fruition. I think the pivot to direct care delivery makes a lot of sense. This is the way that the other hospital districts in the state are organized, and Travis County has empowered Central Health as the key agent to be the effector of these health services. We should step forward and lead. As I look at that plan, I'm curious about some elements that may have been in the conversation, so I want to acknowledge that I only have some access to information, and these may well already be in the works with the leadership team and the board, so I don't want to make that assumption that they're not. But as I said earlier, I'm focused on healthcare outcomes, so I want to understand where are we failing to make sure that breast cancer screening is happening and why? How do we get past that? How are we going to measure that specifically? Where are the mortality gaps? And can we think about that in terms of the perhaps 5 zip codes where that is the sharpest and the reasons why? Let's spend some time digging deeply into the outcomes of health that really matter to us. I also noticed the plan perhaps could spend some time thinking about innovation. We are in a period where we're learning a lot about how we effectively use limited resources to meet communities of need. There's a lot we can learn from around the country, maybe even around the world. Ask what works in the Austin context, do that in conversation with our patients and our partners. Test that and implement that. So care delivery models, how do we get even further upstream? I really believe that if we could prevent the need for hospitalization, almost everybody would choose that rather than be hospitalized. So let's get upstream and let's prevent the problems that we can, thinking about health broadly. And then digital health is taking off these days. There will always be the need for a human being to be the one to build that relationship, to earn that trust. I believe that it's a long time before an artificial intelligence machine will do that better than a human being. But there are many things that the AI and digital health can empower, remove that human time and free up that time to do the things that really matter around relationships and trust. So are we asking those questions? Can we build some of those in the out years? So I'd love to see some of that. And I'll go a little further with a nod to my colleague, Jason Fournier, and Sharon Alvis. I'm not sure she's in the room. Yes, perfect. There are additional opportunities as we move further into this. As we become really good at keeping people healthy and well out of the hospital, we can access lots of different sources of funding that will allow us to then go even further, get underneath that tip of the iceberg and try and understand who is really not being served here. How do we reach them? What would that take? Build for that. Be able to be bold and create some things. Because of the nature of our funding, we are more free to innovate and really listen to our patients and build what they truly need than perhaps other more traditional healthcare organizations are. We should use that freedom because equity is about matching that need to our services in the time and place where it occurs. So I would love to see us leaning even further in those areas in the health equity plan. But overall, the plan is excellent, and it would be a privilege to help us make sure that it becomes a reality.
So you mentioned innovation and technology, and we have a question from somebody on Facebook about cybersecurity. I think we may have been spammed 15 minutes before I walked in the room, and I asked Anastasia, is this real? But I do have a question about cybersecurity. It is incredibly important to a healthcare organization like Central Health. Could you talk about your experience with cybersecurity, how you would prioritize that, maybe any thoughts of or case studies that you've been involved with that might be applicable? Well, that's a hard word for me to say here at Central Health.
Unfortunately, I have to share that my health system was the victim of a complete cybersecurity takedown. So just before, around Thanksgiving last year at One Broken Health, our entire IT system was taken down. Our internet, our email, Epic, thankfully, was quarantined, so the data was not compromised, but we cut all the links, we severed the bridges until we could clean all of our work. And for a period of approximately 2 months, we were struggling to keep people safe. Some things that we had forgotten were a problem, like how do I draw a lab, send it to the lab, get it processed, get it back to the chart for the right patient in a reasonable amount of time. Those processes exploded, and we had to go back to basics. In real time, we were trying to triage and respond and just keep people safe. And I won't go further into this, but just to share, I have experienced the dark side of this deeply. It is a disaster, unfortunately, and it was not a fault of our organization per se. My mother actually has worked in cybersecurity for a long time, and she shares that there used to be a sort of honor among thieves, if you will. The idea that you don't target health, you don't target education. And somewhere along the way, we seem to have severed that tie. We are in a new normal. It breaks my heart that we would do that, but it's where we are. So I just want to emphasize how critical that is. That means that sometimes there are going to be steps like your password has to be longer, and it may have to change more frequently. You may need to manage some of the steps that are required to make our system safe. We might have to have really tight control over who has access to our internal systems and so on. I saw a video last night on 2022 by the numbers, and I believe one of our cybersecurity leaders held up a card that said something like 8,000 cyber attacks prevented this year. We need to do more of that. It's probably going to be even more of those coming inbound, and we just have to have an appropriately smart defensive posture that doesn't prevent us from doing the daily work. It's a cost of doing business. It is important, and we won't underinvest in that because the disaster on the other side of the total takedown, must be avoided at all costs if we can.
Well, maybe I get credit for preventing one cyber attack, right, this morning. So you've been here for almost 4 hours. So in your opinion, what are the biggest challenges facing Central Health, but probably just as important, what are some of the biggest opportunities that you see, again, 4 hours into your visit?
Sure. There are 4 challenges and 4 opportunities I'd like to share. It's a partial list, obviously. But challenge number 1 is what I would call alignment of incentives across stakeholders. And in some ways, I credit, I believe, Anne and others in the board who shared with me that this is one of the threats and challenges that they're most worried about. So we've got a lot of good people with good intentions at the city, the county, the state, our medical school, hospital system, community health partners, social services partners, our own internal stakeholders, our patients, all 3 categories I mentioned and more. There's going to be differences of opinion. There's going to be different goals. Many of them, I believe, are with the best intention, and we share equity as a core goal. It may be that sometimes even that is not our core priority, and we need to navigate through all of that. And we will. But that is one of the most important things, is to recognize that we exist in a complex political space, and we need to do our work in the light of day and with great integrity and navigating those alignment of incentives. Challenge number 2, I would be remiss in not mentioning the legal suits that I'm aware of. The outcomes of those suits are of great importance, great significance to the organization, and they will necessarily require the due amount of time, my time, and that is a challenge that may take some of my focus and time away from moving the work forward as we've discussed, but it, again, must be done, sort of like our cybersecurity conversation. So that's challenge number 2. Challenge number 3, I would say, is actually managing the rapid growth. An organization that where everybody knew each other, there was just a sense of trust and agreement, mission. We didn't necessarily have to be quite as explicit or intentional. We weren't growing by leaps and bounds. We may need to evolve and lay down very clearly what are the core values? What are the behaviors that lift up those core values? What are the ways that we hardwire that in to how we hire on board, what our meetings look like, what the cadence of our conversation is like, so that the mission and people remain firmly at the center and vibrant as we grow. And then challenge number 4 is this pivot to direct care delivery. This is a new set of activities and behaviors and skills. And in this case, I feel confident that given my background, we can make this turn together. But it is an important challenge that we need to put in view. So opportunities. Opportunity 1 is to get the healthcare delivery right. We don't have to build the way that it's always been done. We can ask the question what truly needs to be accomplished. Trust, whole person care, no delays in care, get it right the first time, culturally concordant, and so on, and we can build for that directly. We don't have to unbuild as much in Austin, Travis County. It's actually an advantage. I would love to see us innovate and take the best practice that's out there, that's been demonstrated to be effective, that works in our context, and build right out of the gates. Opportunity 2 is to get the culture right. So that same flip side of the rapid growth, if we do this right, if we lay down a really solid and firm set of practices, routines, intentions, assessments, conversations, so that the culture goes from strength to strength, and this one trunk, many branches gets even larger, connects out to our core partners. We are creating one conversation around health. We have the same shared goals. That leads into opportunity 3, which is to get the relationships right. There are already great relationships in all directions of Central Health, but there may be opportunities to be even better, to collaborate better, to find those areas of shared objectives, to recognize that there are incredible aligned incentives, for example, between an organization that's really good at preventive upstream care, whole person care, in actually safely catching people out of the hospital or out of the emergency room, safely keeping them well out of the hospital, reducing hospital congestion, reducing boarding in the emergency department, helping the hospital run more effectively, more financially viable, better quality, all of which would be entirely within the goals of our community, be better care, better health, lower cost. I really believe we can do that together. And so that leads to opportunity 4. The most important opportunity is that we can improve the health of the people of Travis County. We can build all the way to the promise of what I believe is here as we think about Central Health. That is a purchaser of care, excuse me, an insurer, an employer, a direct provider of care. We have all pieces of the triangle here. We could work together with our partners. Excuse me.
There's water here. Welcome to Cedar Fever in Austin. One of the many benefits of living here.
I took a COVID test last night. This is not COVID.
We may have some extras if we need them.
And we could reduce the health disparities. We could understand why people are dying earlier. We could be well on our way and have that conversation over time. This will take many years, but at least it's the right question, I believe, to ask. It should orient and organize all of our work.
I'll let you take another sip of water. I also want to recognize one of our county commissioners, Ann Howard, has joined us. And I have a question that I'm going to read to you, and then we are going to take questions from the audience. So if some of you have been sitting on your hands, get ready to raise your hand. But this is a question regarding jail diversion programs. Drawing upon your experience or insights, could you talk about how jail diversion programs can be used to manage medical costs, spam call, and reduce the cycle of incarceration? If you haven't worked directly in this area, talk about how Central Health could work and or support other government agencies and community partners to enhance access to both medical and behavioral health services with the primary goal of reducing recidivism and promoting greater health equity. That's a long question, but
just to clarify, when we say jail diversion, we mean that as instead of incarcerating somebody, we might help treat the underlying. Exactly. Yeah, perfect. So, being incarcerated is a little bit like being hospitalized. We don't create a whole lot of health in the hospital. We don't create health by incarcerating somebody. There are some exceptions in the hospital. I will definitely acknowledge those when we're giving birth, for example. There are health creating opportunities, but by and large, we are creating the health somewhere else. We're fixing a problem or managing a problem in the hospital or in a jail setting. As we know, there are many reasons why somebody might have ended up in a position where they broke a law, they were endeavoring to meet a core basic need, or perhaps they were suffering from substance use or mental health disorder or deep poverty in a way that any of us in that situation, if we're honest, might find ourselves making a choice that made sense in that context, right? That I would start with the place of just compassion and recognizing that health as a human right applies here as well. And that we have a great deal of evidence that suggests that incarceration is not the most effective way to reduce recidivism. It's not the most effective way to spend the limited resources of the public. We incarcerate far too many people, and we incarcerate people in a very disproportionate way. Those who are most vulnerable amongst us are profiled and convicted and incarcerated at a far higher level. This was certainly a challenge in central Brooklyn and Brownsville, where I was most recently. I imagine it may be a challenge here. So yes, any opportunity we can take to understand, what do you really need? What does whole person care look like to you? You may have committed a crime, but you're still a human being. What do you need? How can we meet you there? How can we do that safely? So if there is a need for the public safety, let's acknowledge that. This is a nuanced conversation. Let's partner with our law enforcement colleagues, our colleagues in the justice system. We should do this together. But with everything that we do, we have to recognize that at the other end of this process, no matter how complicated the process, there is a human being. And that human being has a basic right, human right to health and compassion and effective services, especially from Central Health. So what can we do to understand those needs and put those into place and use incarceration as a last resort, just like we ought to use hospitalization as a last resort? That will be my aspiration here.
Could you talk about your understanding of financing very complex organizations, taxpayer-funded organizations, and then explaining complex financial, legal issues to elected officials in September at a Travis County Commissioner's budget meeting, but not only to elected officials, but also to our community, helping our community, the people that we serve, or that perhaps we aren't serving yet but should be serving, so they understand how we're financed, how that money is used to improve the health of the community.
I have a great deal of experience as a senior health leader translating complex topics to a broad range of audiences. Patients, families, community, students, residents, healthcare providers, physicians, executive leadership, public health leaders, partnering with donors and public health leaders to try to accomplish major campaigns. For example, I mentioned briefly that together with the Minister of Health and his team, we effectively scaled up HIV services across the country of Liberia. So this is a familiar space. I will add that whether we're in a negotiation or we're in a reporting situation or we're trying to hire somebody we really want on the team, in the end, we're all human. What I mean by that is that if we take the time to understand who you are and what really matters to you, who your stakeholders are, what success looks like to you, where our success points might be shared, that gives us a much more range to connect around the things that we share rather than things that we don't agree on. And then if we show up in a way that is high trust, high integrity, we keep our commitments. What you see is what you get. You know what I stand for, what we stand for. We're here to improve the health of the people of Travis County. This is our constituency that we're ultimately responsible to. And people come to understand who you are and what they can expect from you. Then there will be situations where we may show up and we may have a difference on the issues and agree at some level, disagree on the issues, but do so within the context of trust and an ongoing relationship and respect, where we can come back to the table again and again and work together, navigating this complex space. I should also mention, in terms of financial management, I have had responsibility for large budgets. In the most recent role, a $65 million a year budget. Within that, actually, a responsibility for leading our value-based care work. So it's getting a little bit wonky for a moment, but this is a way in which we pay for the outcomes of care and not just the transactions of care. If somebody stays healthier, then you actually make more money that you can then use to reach more people. So I had responsibility for that management, about 50,000 patients, about $250 million across our system. And so there's experience there that I'll be able to draw on. And then I will add that I endeavor to create environments that are really high trust, where the people who work with me, who work for me, feel safe offering me feedback. Jason and I were talking about this just in the previous conversation. I know that I'm human. I know that I won't have this right in any given moment. I know that I have blind spots as part of being human. And I expect and rely and trust the people around me to want me to be better, to want me to be successful, and to help me see what I don't see, help me learn and improve. And I will commit to being a continuous listener and get better constantly as we go and close any gaps that might be there out of the gates.
So I want to see if anyone in the room has a question. I've got more questions coming in via Facebook Live, but we could start with somebody in the room, and then I will head in this way. Why don't we?
Sure. I'm Regina Rogoff. I'm CEO of People's Community Clinic, one of the partner agencies. But my question isn't about the clinic. It's really on a bigger level. I like the way you talked about opportunities and challenges. I guess I'm wondering, coming from California, New York, and Massachusetts, whether you see the Texas failure to expand Medicaid as a challenge and as an opportunity.
Thank you for that question, Regina, and thank you for the work that you do. It's really interesting, actually, having come from the outside, if you will. The first part of the headline, the failure to expand Medicaid, I've known about, and I imagine you know where my politics stand on that. I really think we ought to do that. But if it's not in the cards, what then? And one of the really interesting and amazing things I've seen is that in the blue bastions of the urban centers of Texas, there has been a response to that challenge that has resulted in a set of conditions, potentials for success that are better than what I've seen, actually, in the settings I've worked in New York and Massachusetts. We have this alignment of clear legal mandate. We have enough money, I believe, to do a lot more and lean into that and not have that be the daily worry. And if we do that effectively, we may be able to, as we get going, really become a model for what's possible. What does an integrated delivery system in the city of Austin, in the county of Travis, look like when we all come together around that conversation about equity? Not just the opportunity, not just the access, but the outcomes and even the mortality, right? Which will take time. And we have a longer conversation, recognizing we're not going to fix this in one quarter or one annual cycle, but it doesn't mean that we don't go there, right? Let's model what it looks like to use this particular context of Travis County within the state of Texas to show what's possible here and be part of that national dialogue. I'm really excited by that opportunity. And to go back to my first comments, optimism is a moral choice. There may be parts of this you're going to tell me it's not rational, and I may agree with you. And we may still choose to make the world by walking it together. Some things become possible when we lean into the right question and work together.
We'll take another question. And also a reminder, from 12 to 12:30, we'll have a meet and greet, so you can talk to Dr. Lee one-on-one and ask your questions as well. But, sir?
Yes, my name is Daniel Perez. I've been living here in this neighborhood since 1961. On Haskell, here on behalf of District 12 LULAC Member 2 and El Concilio, my leaders here today, Gavin Hernandez. You mentioned earlier about health for everybody. We have a lot of homeless people that live here in this neighborhood, especially along Lady Bird Lake.
Yeah.
Winter's fixing to kick in. We don't have medical people to come down there and check on them. A lot of them live under the bridge. A lot of them live along the lake. We're talking about hundreds, maybe 1,000 at any given time during the winter.
Okay.
And if you live in this neighborhood, you know a lot of those people they're neglected because they're homeless. And you said earlier that health is for everybody, no matter what gender, what color. And they don't get attention from health department. And we need to keep an eye on them because they're Americans just like all of us are in here. You know, we're all together in this. And some of the schools don't have the medical that they need, especially neighborhoods like Doe Valley, Dove Springs. They don't get all that. We don't have clinics over there where they can go and people, especially people from other countries, people from here, we don't have that. Medical field, my sister's been working at Dell Hospital, even was Breckenridge for 43 years. And we just don't have that. And when you say for all people, no matter what color, it's never been like that in Travis County. You're telling me something that I've been there, done that. 62 years of my life in this neighborhood. It has a lot to do with color. So when you say stuff like for all colors, it's not like that at all. So do your numbers. Look down at how many people get attended to. And it's always going to be white people that get all attended to. Always do your numbers before you come in here and you say all colors. You might mean good, and your intentions might be in a good intentions, but it's not been like that since I was growing up in this neighborhood up to this day. So if you're going to do something for us and make changes, make those changes. But keep your word because and then it never happens. This last guy we had, it didn't work out. You know, some of these judges, they don't work out. It's always been about color. And so again, I like your intentions, and maybe you're the person that's going to make the difference. Maybe a lot of people in here listening today, maybe you're that person that we need. But please try to help the minorities too. That's all I ask. Thank you.
Gracias, Daniel, por esa pregunta y por esa advocacia. I'll respond in English. I appreciate you raising the reality of your experience and your colleagues and the folks, hundreds or thousands, who are sleeping outside, maybe sleeping rough. I get that. That's what I've been dedicated to all my life. I understand that this takes time. There are many underlying factors. The structural racism, if you will, goes back a long time, right? a long time. And you can trace its roots in policies, who could and couldn't access services, what zip code you were in, do you have to cross over the I-35 line. I'm just beginning to get educated, and I want to get educated more. I need to understand your experience. I need to understand the voice, not just your voice, but others who you think I need to listen to. Because we need to lift up and focus. We won't be able to solve every problem all at once. I said earlier, we have to focus. But certainly, if there are people sleeping rough under the bridge, in Boston, that community in healthcare for the homeless, there's a famous picture that Jim McConnell, one of my mentors, put up. And there's a little park called Mousy Park right in front of the Mass General Hospital, in the shadow of that great hospital. And that picture was time-lapsed year after year. And Jim used that picture to make the point that this was a 50% mortality condition. When you were sleeping rough out on the streets of Boston, this is one of the most dangerous conditions that you can possibly have. Jim was an incredibly humble leader who began his career by washing the feet of the people who were living rough. He said, if you understand someone's feet, you understand a lot about what they're going through, and you can earn their trust, literally down on a stool at their feet, washing their feet. This is the upbringing that I've had. I don't pretend to think this is easy to do, but if as CEO, if I focus our efforts, laser focused on this issue, we lift that up, we ask, what's missing here? Who's not at the table? Where do we begin? How do we check our numbers and make sure that we're actually accomplishing our goals? And if we're not, how do we adjust dynamically? How do we use the fact that, as far as I can understand it, Central Health has quite a bit of flexibility in its funding sources to be more nimble and to adjust more quickly, perhaps. I may have that wrong, but I'm hopeful that's true, so that we can more quickly close some of those gaps that are real and that you're speaking to. I believe we can make progress. I don't know that I know that we're not going to solve things immediately, but I hope, if entrusted with this opportunity, that you and your colleagues will say after a couple, 3 years, you know, we see this, and this that we helped prioritize, and we're glad to see this progress moving forward. We're going in the right direction, and it feels like a shared conversation. So that would be my commitment in this role. Thank you for the question.
We'll take one more question from the audience, and then we do need to begin to wrap up, and you'll have a chance to ask Dr. Lee one-on-one any question that you like. So,
Patrick, it has been an honor and a pleasure to hear you talk about whole person care and how we would take care of people in our community. Sorry, it just means a lot. But what I want to know, the complexity of many situations, but the one you're coming into in Austin at Central Health, how would you start? How would you begin to craft the vision? What are your first steps? How do we bring people in? Specifically, the people that are going to make things happen. What are your thoughts about how you would begin?
I'm not sure I got your name. Nora. Thank you for that question, Nora. Step one is humility. I'm coming from the outside. I don't know what all of you know. I have a great deal to learn. Step two is listening deeply, broadly, continuously, as I've discussed. The first several months, and even extending into the first year, you should see me listening in all kinds of ways, following the guidance of my team to help me understand where and when and in what order I should be listening to make sure I'm getting the right input. Beyond listening is observation. So where we have strengths, where we have weaknesses, opportunities, I would go and try to observe that place. Maybe we're on the phone in an enrollment conversation. Maybe it's one of our IT team members wrestling with the cybersecurity defense layer there. Maybe we're out in the community. Maybe we're in the clinical setting. So I understand deeply what we can build on and grow and where we need to get on the best possible footing. Over the course of that first year, my focus would be on listening, learning, building relationships, earning trust, and then setting some early priorities based on this assessment. What are we going to do first to improve our footing, to improve our ability to deliver on that health equity plan, to deliver on those commitments, to really, truly see the least among us and go there and change the facts of the care, the outcomes of the care. Heading into years 2 and 3, hopefully we are now executing those early priorities. We are beginning to firmly establish the direct care delivery, which is going to take some learning and some growing, but hopefully by that point we're seeing that we are coming up alongside and maybe even setting the standard for what that care can look like in this setting. And we're beginning to look at innovation opportunities. So as I mentioned earlier, the care delivery model, going upstream, maybe working with our partners in the jails, thinking about digital health, generative AI. As I understand, there's a lot of forward-thinking tech people in Austin. Let's have that conversation. What's that look like for equity? Maybe there's other partners who want to come in and empower us further with resources or funding or expertise and so on. How do we begin to make that happen so that in years 4 and 5, we are developing the most promising innovations further. We're going further than perhaps where the original equity plan had contemplated. By that point, if we're doing our jobs well, we will begin to substantially reduce some of those inequities. Excuse me. Some of those gaps we focused on, and begin our process of planning for the next 5 years.
Thank you, Dr. Lee. Can we?
Reduce access right now? If I were to see the doctor, it takes me $5. If I want to see a dentist, it might take me 6 to 9 months. So how do you plan to reduce that?
Take that question.
Sure, go ahead. Yeah, go ahead. Are you talking about central health or community care?
Central.
Okay. So my belief and what I've seen occur before is that when we put all these pieces into place that I've discussed, you ought to be able to see your primary care doctor today, what we call an open access model. There are many things that go into doing that, and for some conditions, within a week might be fine, but certainly not 5 months, 6 months. So it'll take a step of assessing where are we relative to best practice, and I'm not talking about fictional things. These kind of open access models exist all over the country, and as I understand it, even in the musculoskeletal space here in Austin, there's been some innovation to take a wait time down from over a year to being able to see somebody very quickly, whether today or tomorrow. And so we have an experience right here in Austin of how that can be done. There are many steps. You have to focus. You have to build for that. I'm not saying it's easy, but it's absolutely possible. And so I agree with you, right? If we're not getting the wait time down, not just for an urgent visit, not just when you have an emergency, but you have something routine, you ought to be able to reach out on the portal, pick up the phone, walk in, and be seen ideally today. It'll take us a while to build to that, but it is absolutely possible, and that will be the goal. And we'd have to be laser focused on that. I'll say one more word about that, which is that when you think about a systems engineering perspective, in any given process, there's the things that are valuable. There's the things that you and I would pay good money for because they transform my experience, they transform my health, and there's everything else. And sometimes there's a lot of the everything else, waiting, mistakes in the process to be redone, taking 5 steps to do something when maybe 1 would get the job done. And so if we develop that focus and look carefully at all the different things that impact your ability to access your medical team today, and rigorously lean into that, teach everyone on the team how to see and solve the right problems in their space today. And again, this takes time. And so there's some expertise in doing that, as I understand it, throughout our enterprise and system. Then we can get there. And we have to get there. That is the essence of you then being able to make that call and not go to the emergency department, let's say, if you have a need, or get way upstream. I'll go even further. In a really mature system, we ought to be able to know if, let's say, you have heart failure. If you stop picking up your medicines and you have severe heart failure, we got about a week before you're going to need to be in the emergency department, maybe less. We should be able to see that in advance and go to you, right, in a way that's acceptable to you and intervene before that event happens. And there are many versions of this as we get really good and we get the data, and we can see ahead of time what's about to happen, and we have your permission because you trust us and you've accepted this level of care. You don't want to go to the hospital either, right? And maybe there's a very good reason why you didn't pick up the meds. Let's bring them to you. Let's make that easy. For a while, let's even have a partner you trust be with you when you take them in the morning. Check your weight, report into the nurse, make sure we're all good, right? Those things can absolutely be done. I'd love to see us do that here.
Thank you, Dr. Lee. Let's give Dr. Lee a warm welcome. Thank you. I would invite you to stick around. Dr. Lee is going to stay here in the room, and you're welcome to meet with him and ask him questions. Just a reminder, we'll do this again on Wednesday at 11 o'clock, same format, so you can join us in person. We would love that. You can also join us via Facebook Live or Zoom. So again, thank you so much for your time. We appreciate it. And
Don't forget, hook 'em horns.
hook 'em horns.